Hey there, welcome back to my channel. Today I'm going to discuss regarding vitamin B12 deficiency. We as medical students, we have learned vitamin B12 deficiency in bits and pieces from first year to final year. So I thought I will integrate all of that and I will present it in front of you. Okay. Hope you are going to enjoy this short session on vitamin B12 deficiency. And for those people who have not subscribed to my channel, hit the subscribe button. So without wasting much time, let's understand under what subheadings are we going to study vitamin B12. So the objectives for this session are, we will look into the daily requirement and sources. We will understand a very important mechanism, that is absorption of vitamin B12. Then we will learn what are the causes of deficiency of vitamin B12. Then coming to the biochemical part, very important to understand the reactions which are catalyzed by vitamin B12, because when we understand the reactions catalyzed by the vitamin B12, that is when we can easily understand the clinical features. And at last, we will see how vitamin B12 can be diagnosed by using laboratory investigations. Okay, so let's start with the daily requirement and sources. So average daily requirement of vitamin B12 is 2 to 3 micrograms, and the rich sources are meat, okay, meat, fish, milk, cheese, eggs, and also fortified cereals. So these are the rich sources. So when we look into the rich sources, what we can understand is that people who are purely vegetarians or even vegans, these are the ones who are more prone to develop vitamin B12 deficiency. Okay, let's understand the absorption. This is the most important part. Okay, so concentrate a bit more on this part. So whenever I take a food which is rich in vitamin B12, this food is going to enter into the stomach. Okay. Now what happens in the stomach? The gastric acid, that is the gastric HCl which is produced in the stomach, that is going to release the vitamin B12 from the food particles. That means gastric acid presence in the stomach is extremely important for extracting the vitamin B12 from the food particles. So the first point here, what we should understand here is that in people, in whom the gastric acid content of the stomach is very less, they may suffer from vitamin B12 deficiency because it is going to affect their absorption. And who are those people in whom the gastric acid secretion is reduced? These are the people who are taking antacids or the drugs which they use for acidity. So these people may suffer from hypochlorhydria or achlorhydria. So such people are more prone to develop vitamin B12 deficiency. Now what has happened right now? Food has entered into the stomach, gastric acid has acted on the food, and vitamin B12 is extracted. Now this vitamin B12 is going to form a complex with a compound which is called as haptocorrin. What is haptocorrin? Haptocorrin is also called as R binder. This haptocorrin is the one which is produced from the salivary glands. Why do you think vitamin B12 has to bind with haptocorrin? Because vitamin B12, once extracted from the food particles, is prone for denaturation by the gastric acid. To prevent the denaturation of the vitamin B12 in the stomach because of the gastric acid, vitamin B12 binds to haptocorrin, and haptocorrin is produced from the salivary glands. Now this complex of vitamin B12 and haptocorrin is going to enter into the duodenum, and what is happening in the duodenum? In the duodenum, the pancreatic enzymes are going to act and they are going to remove the haptocorrin from this complex of B12 and haptocorrin. So now haptocorrin is released. Next, what is going to happen? Now vitamin B12 is free. Now what is going to happen? A very important step is going to take place. Vitamin B12 is now going to bind with intrinsic factor. What is this intrinsic factor? Intrinsic factor is also called as intrinsic factor of Castle. This is the one which is produced from very important cells in the stomach which are called as the parietal cells. These are the same cells which also secrete hydrochloric acid in the stomach. Okay, so vitamin B12 binds with the intrinsic factor. Now this complex from the duodenum is going to move to the terminal ileum. Remember, terminal ileum is the site where vitamin B12 is going to get absorbed. So now what is going to happen is this complex of vitamin B12 and intrinsic factor is going to bind to receptors in the terminal ileum, which are called as tubulin receptors. Okay, and by means of endocytosis, vitamin B12 enters into the enterocytes and then it is circulated by means of transport proteins like transcobalamin. So absorption part is extremely important, because if anything is wrong with the absorption part, then vitamin B12 is not absorbed and it may result in vitamin B12 deficiency. Starting from the gastric acid which is produced in the stomach, haptocorrin which is produced in the salivary glands, the pancreatic enzymes which are acting on the haptocorrin and B12 complex and hence helping in removing the haptocorrin from vitamin B12, the intrinsic factor of castle which is again produced from the stomach. So there are two important things in the stomach. One is the gastric acid, another thing is the intrinsic factor of castle. And we also need the intactness of the ileum, because it is the site of absorption of vitamin B12 is at the ileum, and we also need the presence of tubulin receptors to which this complex of B12 and intrinsic factor is going to bind, and it causes endocytosis and absorption of vitamin B12. Remember this part. Next, let's see the causes of deficiency. First and foremost cause could be decreased intake, as happens in poverty, as can also happen in purely vegetarian people or even vegan people. So this could be the cause. So intake is less. Next, it could be also because of increase in the demand. Increase in demand can occur in pregnancy. It can also occur in lactation. It can also occur in hyperthyroidism. And the most important cause is impaired absorption. So what could be the causes of impaired absorption? Any malabsorption syndromes, okay? Partial gastrectomy, the person has undergone partial gastrectomy, that means half of his stomach is removed out surgically. Now he is going to have lack of both gastric acid as well as intrinsic factor. So when gastric acid and intrinsic factor are not there, it may result in malabsorption. It may also occur if the person has undergone removal of the ileum, that is ileal resection, because we know that the site of absorption of vitamin B12 is ileum. It can also occur in ileal diseases, okay, like ileitis, inflammatory bowel syndrome. It can also occur in very important disorder which is called as atrophic gastritis or autoimmune gastritis. What is this atrophic or autoimmune gastritis? In this condition, autoantibodies are there which are acting against the parietal cells. So there is disruption of the parietal cell because of the autoimmunity. Now lack of parietal cells means there is a lack of intrinsic factor of Castle, and there is lack of intrinsic factor of Castle, the vitamin B12 absorption is not going to take place, and hence the anemia which is developing because of this atrophic gastritis or autoimmune gastritis is what is called as pernicious anemia. Okay, it has been given a special name which is called as a pernicious anemia. Here the features will be same as that of the vitamin B12 deficiency, but the cause is different. That means how much ever vitamin B12 I am giving orally, it is not going to suffice, because I have to identify the cause when the person comes to me with vitamin B12 deficiency. Okay, it could be also because of pancreatic insufficiency. Why pancreatic insufficiency? Because it's the pancreatic enzymes which are going to remove the haptocorrin from vitamin B12. Now if the haptocorrin is not removed from vitamin B12, then the vitamin B12 cannot bind to the intrinsic factor. You're getting the point. So if this intrinsic factor binding with vitamin B12 is not taking place, there is no absorption. So pancreatic insufficiency is also one of the important causes of deficiency or malabsorption of vitamin B12. It could be also because of intestinal bacterial overgrowth. We all know that there is bacteria in the intestine, and these bacteria also utilize vitamin B12. If at all there is a condition where there is bacterial overgrowth, then what is going to happen? Then these bacteria are the one which are going to utilize vitamin B12 more and more, and hence the amount of vitamin B12 which is absorbed in the intestines is going to be less. And last but not the least, of course, one of the rarest cause is mutation of the receptor, which is called as tubulin receptor mutation, because the complex of IF and B12 is going to get absorbed by binding to this receptor. So remember, all these points we have to keep in mind when we are dealing with a patient who is having vitamin B12 deficiency. Okay. And these days, one very important drug which is implicated in causing vitamin B12 deficiency, that is nothing but our metformin. So this is the drug of choice in patients who are suffering from type 2 diabetes mellitus. So if at all you are treating a diabetes patient who is on metformin and who present to you with symptoms and signs of vitamin B12 deficiency, always do investigate the case thoroughly to find out the causes of deficiency. So remember this cause also. So now let's understand the reactions which are catalyzed by vitamin B12. There are three important reactions which are catalyzed by vitamin B12. Remember, I'm not going into the in-depth details of this. This you would have already studied in your biochemistry classes. The first and foremost thing is conversion of deoxyuridine monophosphate into deoxythymidine monophosphate. So if this reaction is not occurring, then formation of thymidine monophosphate is going to suffer. So if thymidine is not formed, because thymine is an important building block of DNA, what is going to happen? This is going to affect DNA maturation. Okay, this is going to affect DNA maturation. So we know that in our body there are cells which have to be produced daily, and the such cells are more with respect to the hematopoietic cells, the RBCs, WBCs, and the platelets. So if DNA maturation is not occurring, then this is going to affect the formation of the new cells. Hence, what is going to happen? There is going to be a reduction in the RBC count, there is going to be a reduction in the WBC count, and there could be also reduction in the platelet count. So usually if all these three things are down, or the amount is less, then that condition is called as pancytopenia. Okay. Next important reaction which is catalyzed by vitamin B12 is conversion of homocysteine into methionine. So if this conversion is not taking place, then what is happening is the amount of homocysteine in the body is going to increase, a condition which is called as homocystinemia. And we all know that if there is homocystinemia, those individuals are more prone for what? They are more prone for thrombosis, and this thrombosis is going to be affecting both arterial system as well as the venous system. So there is an increased risk of both arterial as well as venous thrombosis. And the third important reaction catalyzed by vitamin B12 is conversion of methyl malonyl CoA into succinyl CoA. So if this is not occurring, what is happening? There is an increase in the concentration of methyl malonyl CoA, and increased concentration of methyl malonyl CoA is going to incorporate abnormal lipids. It is going to incorporate abnormal lipids where? Into the myelin sheath. Okay, now this is going to lead to central nervous system or neurological symptom. So these are the three important reactions catalyzed by vitamin B12, and I told you what is going to happen if these three important reactions are not going to take place in the body because of lack of vitamin B12. Next, let's go to the clinical features. So in the clinical features, we are going to have the features which are due to anemia, any anemia. So what are these? The person is going to have fatigue and also tiredness. On examination, the person will show us pallor. Apart from that, there could be glossitis or inflammation of the tongue. So the inflammation of the tongue looks something like this. Okay, here we can see in the diagram. This is what is called as beefy tongue. Okay, this is what is called as beefy tongue. Okay, there could be also angular chelosis. Here we can see there is also inflammation of the angle of the mouth, which is called as angular chelosis. There could be an increased risk of infections. Why increased risk of infection? Because of lack of WBCs. There could be an increased risk of thrombosis because of increase in the concentration of homocysteine. and there could be a plethora of neurological signs and symptoms like headache, numbness, tingling sensation, irritability, cognitive impairment, and visual loss. Why visual loss? Because of optic nerve neuropathy. Okay, because of optic nerve neuropathy. And I have told you why there is neurological problems in vitamin B12 deficiency. The main reason is increase in the concentration of methyl malonic CoA. Okay, and apart from this, if left untreated, it can also result in a very important disorder which is called as subacute combined degeneration of the spinal cord. Remember, subacute combined degeneration of the spinal cord is going to initially affect the dorsal column, and hence all the sensations which are carried by the dorsal column will be impaired. Most importantly, it is going to affect the proprioception. So whenever there is lack of proprioception, it is going to result in what is called as sensory ataxia. Okay, so remember, vitamin B12 deficiency is just not going to cause anemia, but it is also associated with lot of systemic disorders, and more so, and to be more specific, the neurological symptoms. So one has to be very careful whenever we are dealing with a case of anemia. We just shouldn't think anemia is just because of iron deficiency and put the patient on iron and folic acid tablets. So whenever a case of anemia is coming to you, I want all of you to investigate the case properly, come to a proper diagnosis, and then start the treatment. Coming to the lab test results, when we do the lab test results, in about 20% of the cases, we are going to see reduction of RBC, WBC, and platelets, all three. That is what is called as pancytopenia. When we do the mean corpuscular volume, it is usually increased. That is because immature cells are entering into the circulation, and hence the size of the cell is going to be larger. Size of the RBC will be larger. That is why the mean corpuscular volume is increased. So an increase in the mean corpuscular volume is suggestive of increase in the size of the RBC, which is called as a macrocyte. Okay, that's why such a kind of anemia is called as macrocytic anemia. Sometimes what we can see is that even these cells, RBCs, are usually not nucleated. Even sometimes we can see the nucleated varieties of the RBCs. That's why such cells are what are called as megaloblasts. Okay, they are called as the megaloblasts. Blast means immature cells, megaloblast means they are bigger cells. Okay, that's why they are called as the megaloblasts. Hence, this kind of anemia is also called as megaloblastic anemia. Remember, megaloblastic anemia need not be only because of vitamin B12 deficiency. It can also occur in folate deficiency or folic acid deficiency. What is going to MCH? MCH is also increased, and the cells which we are going to see in the peripheral blood smear are macrocytic cells. They are going to lack the central pallor. I'll show you a diagram of that. We can also see hypersegmented neutrophils. Again, this is a feature of immaturity of the cells. Usually neutrophils will have 2 to 5 lobes, but when we look into the picture or in the peripheral blood smear, we can see neutrophils with more than 5 lobes, 6, 7, 8, 9, even 10 lobes have also been documented. Next, we can see Cabot ring, that is figure of 8 appearance within the RBC. We can see a blue dot within the RBC, which are called as the Howell-Jolly bodies, and we can also see basophilic stifling. Remember, the Cabot ring, Howell-Jolly bodies, and basophilic stifling, all these three are not specific causes of specific features, not causes, specific features of vitamin B12 deficiency. If all these three things are present, these are features of dyserythropoiesis. Okay, and when we do serum vitamin B12 levels, the normal serum vitamin B12 levels is 200 to 900 picograms per ml. If it is somewhere between like 300 to 400, then that is called as a borderline vitamin B12 deficiency, and less than 200 milligrams per picogram per ml is suggestive of definitive vitamin B12 deficiency. Apart from these days we can also do two important tests. What are those? One is we can estimate the levels of the homocysteine. As I have told you, homocysteine to methionine conversion doesn't take place, so homocysteine levels will be usually increased. Second is we can also estimate the levels of methyl malonic CoA. Okay, even these levels will be also increased. So both these tests are very sensitive tests which can identify vitamin B12 deficiency, homocysteinemia, and excessive amount of methyl malonyl CoA. Okay, so these are the laboratory test results. Now let's see some of the pictures of the diagrams here. Here we can see this cell. Okay, this is a normal looking RBC. The size is also normal, and here we can see that there is a central space here. This is what is called as the central pallor. But in comparison with this cell, you see these cells, these one. So how do they look like? They are larger than this cell. Okay, even we can compare with this cell, they are larger, and many of these cells, they don't have the central pallor. So these cells are what are called as macrocytes. Okay, these are the one which are called as macrocytes. Hence this anemia is called as the macrocytic anemia. Okay, so this is the first photograph which is showing you macrocytes. Now let's come to the second photograph, and I want you to concentrate on this cell. So as we see this cell, can you identify which cell is that? Yes, that's a neutrophil. It's very easy to identify, and if you just start counting the lobes of the nucleus, these are more than 5 lobes. So this is hypersegmented neutrophil. Hypersegmented neutrophil, one more feature of immaturity, and almost a very important feature which is seen in vitamin B12 deficiency. What you can see here, what did I tell you? Three features of dyserythropoiesis. Here you can see figure of 8 appearance. Okay, this is the third diagram which is showing you what is called as the Cabot ring. And here you can see this blue dot, yes, where arrow is pointing to. These are what are called as Howell-Jolly bodies. And here you can see this is the RBC. Okay, here also this is an RBC, bigger RBC without any central pallor. And here we can see blue dots. This is what is called as basophilic stiffling. Okay, so Cabot rings, Howell-Jolly bodies, and basophilic stiffling, all these are features of dyserythropoiesis. So I hope I have made you understand the concept behind the vitamin B12 deficiency, and objectives are fulfilled. The daily requirement 2 to 3 micrograms per day. We have seen the rich sources. Basically, it is the non-vegetarian food like fish, meat, milk products, which are rich sources of vitamin B12. Very importantly, we have understood the absorption of the vitamin B12. What are all the things we need? We need haptocorine, we need the intactness of the stomach, we need pancreatic enzymes, we also need the terminal ileum along with a functioning tubulin receptor for its absorption. So if anything wrong with these things, is going to lead to malabsorption of vitamin B12, which can cause deficiency. Next, we have seen 3 important causes of deficiency: impaired intake, excessive demand, and malabsorption. 3 important reactions catalyzed by vitamin B12. One is formation of thymidine, second one is conversion of homocysteine into methionine, third one is conversion of methyl malonic CoA into succinyl CoA. Then we have seen the clinical features in detail. Remember the neurological features and the neurological complications, and then we have also looked into the laboratory diagnosis. Now you can ask me why I have not included the treatment. Because treatment, we will say only one thing: treat the cause. Okay, if you find out that the cause is because of inadequate intake, increase the intake. Ask the person to eat the food which is rich in vitamin B12, and if he is a vegetarian, then you can supplement vitamin B12 by oral medications. But even if there is a reason of increase in the demand, you can do the same thing. But if it is occurring because of the malabsorption, find out the cause of the malabsorption, and we can give injectable formulations of cyanocobalamines. Okay, so this is with regard to the vitamin B12. I hope you have liked this video and you have understood the concept behind vitamin B12. Remember, a very important anemia which we will deal with the patients. So if you have liked this video, kindly hit the like button there and subscribe to my channel. Thank you for watching. See you again.